Good morning, everybody. Thank you so much for joining. It's great to see you. I'm Rachel Krug, the CEO of Virtual Fields. Virtual Fields is an exceptional eye exam experience with visual fields, color vision, and pupillometry exams in a comfortable, patient-friendly headset. Today, we have Dr. Rafieetary with us. Thanks so much for joining, Doctor. Feel free to introduce yourself and tell us a little bit about your practice. We're curious to hear from you.
Thank you, Rachel, for having me here. Good morning, everybody. I'm Mohammad Rafieetary. This week, I'm celebrating 28 years of practicing at the Charles Retina Institute. So in 1996, I joined the very well-regarded vitreoretinal surgeon, Dr. Steve Charles, and over the last 28 years, the practice has grown to a multi-physician, one of which is my own oldest son, who's one of the retina specialists. Multi-practice, we have offices in the Western Tennessee, Eastern Arkansas, and Northern Mississippi. In fact, this morning, I'm seeing patients in one of our satellites at Oxford, Mississippi, which is the home of Old Miss. So our patient population primarily is patients with vascular disease like diabetic retinopathy, macular degeneration, and then a whole host of, epiretinal membrane, retinal detachment, uveitis patients, posterior uveitis patients, a whole host of vitreoretinal diseases. So we keep busy taking care of patients.
Thank you for that intro. Turning to today's topic on AMD, let's start out with some information on patient demographics. Who is more likely to get AMD?
So age-related macular degeneration, as the name suggests, is an aging-related disease. So the first risk factor or the primary risk factor is aging. And a couple of decades ago or so far, the US Census Bureau estimated that as of 2010, 10,000 Americans are going to turn to age 65 every day. Now we are in the 2020s. So if you imagine, many of these folks now are turning to the age 75. So if you look at the statistics, and there are differences from study to study, but generally speaking, people who are in their 40s to about mid-40s, they have about 2% chance of demonstrating some signs of or symptoms of age-related macular degeneration. But by the time you reach age 85, 50% of patients that are at the age of 85 have some degree of age-related macular degeneration. In fact, if you look at patients in their 50s, 1 out of 100 has AMD and 1 out of 10 has visual threatening AMD. So this is an everyday patient population in our practices, especially if you see adult patients. If you see younger patients, if you see somebody in their 18, 20, one of the problems I see in primarily eye care, we always think in these cubicles of what happens until next year, come back in a year, come back in 6 months. But if you're seeing a 20-year-old, you have to imagine what is the visual status of this patient when they are 70 years old or 80-year-old, because people are living longer and longer. I see patients frequently or every day, 99 years old, 102 years old, 90-year-old, celebrating my 100th birthday. So this is our patient population. So there are other risk factors too. Smoking is a big one.
Okay.
When you see patients from rural communities, and in my practice, we see a mix of patients, rural community, metropolitan patients, suburban patients. Rural patients smoke 10 cigarettes more a day than patients who live in metropolitan areas. So we have to look into these sort of risk factors, comorbidities, hypertension, cholesterol, obesity, sleep apnea. We have to look for all these outside of the box things that may play a role not only in AMD, but other vitreoretinal diseases.
That makes sense. What are the symptoms a patient with AMD would tell you?
So you can't always rely on symptomatology, but for the most part, classically, the first symptom of patients who have age-related macular degeneration that may not even demonstrate any clinical sign is the poor ability to see in dim illumination. And then it goes on to is getting hard to read, is, I can't see well. I can't, as it progresses, I cannot recognize facial features. I have a hard time driving at night. A lot of these symptoms are also associated with other eye diseases, dry eyes, cataracts, any one of these could cause symptoms like that. So when we have symptoms like this, then we have to look to see if the anterior segment is normal or has any abnormalities, if the posterior segment is normal and has any abnormalities. And we have to always remember there are patients who demonstrate more than one disease. You could have a patient who has AMD and also has glaucoma. I saw one yesterday. Her vision loss is more glaucoma related than macular degeneration. So you have to pay attention not to lose sight of other comorbidities that these patients have.
That makes sense. What technology do you use? What functional testing do you do? And what structural testing do you do?
So as far as functional testing, one of the things that is the primary part of a comprehensive eye exam. We always start from a functional standpoint, but Snellen acuity. Snellen acuity is standard of care in our industry, but it really fails to demonstrate a lot of patients who have bad disease. I saw a gentleman earlier today who has macular telangiectasia. He says he's a hunter. He cannot shoot with the eye, but his Snellen acuity is 20/30. So when you look at his OCT, there's a lot of structural damage to the middle of the eye, but his Snellen acuity doesn't show that. So then we go with like low luminance, contrast sensitivity. Now, having said that, in primary care setting, there is room for doing things like visual field testing, a 10-2 on these patients, or if you suspect glaucoma, do a 10-2 and then do a 24-2, or combine these technologies to give you the best yield as figuring out what the patient has. But the use of technology, and I have this in the slide down here, that we have to, not every practitioner has every piece of equipment available to them, but what you have available to you, you have to put to use. And within the realm of taking care of patients with eye disease, for the most part, a fundus camera, an OCT, and a visual field actually is one of the things that every practitioner should have, whether you see AMD patients or not, because visual field plays a very big role in diagnosing patients with glaucoma, unexplainable vision loss, maybe neuro-ophthalmic disorders, so we have to resort to these when we can't explain it by just looking at the patient or talking to the patient.
Gotcha. Thanks for that. I know there's some new notable research on AMD. Could you walk us through that research?
So with respect to one of the hottest things these days is the two recently FDA-approved drugs that we have for geographic atrophy. That has opened up a lot of excitement because this was a patient population that we used to probably not even pay much attention to them because you couldn't do much but just the things about nutrition and antioxidants, not smoking, low vision rehabilitation. Now we have something hopefully to slow down the progression of geographic atrophy. So there is still research going on, clinical trials of perhaps other novel agents to treat these patients. In the realm of wet macular degeneration or neovascular macular degeneration, there's research and clinical trials going on genetic treatment, the viral vectors that you can inject under the retina or in the suprachoroidal space where the retinal pigment epithelium becomes a pharmaceutical factory, so the patients don't have to go through this burden of monthly injections, the port delivery systems, things like that. So part of it, again, is this is an increasing patient population. A lot of folks are going to suffer visual loss from this condition. And as I said earlier, patients are getting older, but these older patients are much more active. And the generationally, the society has changed. Many years ago, an older patient was being cared by the family who they lived together. These days, a lot of these people have to live by themselves. Their children live in other homes. They want to still drive. They want to be active. They want to go play golf. I was joking with an older lady one time who was having to have surgery. She said, "What are the things I shouldn't do?" I said, "Well, you shouldn't do parachuting and bungee jumping." She actually said she parachutes. She's an older, it really surprised me. I mean, these folks do things that is outside of our mind, you know. And then again, we have to pay attention and we have to come up with better ways of taking care of these patients.
Sure. Have you had any interesting patient cases recently? I know you have a couple slides prepared for us of one. I'd love you to walk us through that patient case.
So if you look at this first slide I have up here, the point of this is, you know, you never know when these patients show up. So the patient that you might seen 10 years ago now shows up with geographic atrophy. So my epic just jumped up. So this case is an interesting case, and these are not too far in between. I had seen this lady in 2012. She comes in the right eye with a very large macular neovascular membrane. And when you look at these patients, you're trying to figure out what's the etiology of this. The etiology of a choroidal neovascular membrane or a macular neovascular membrane is usually age-related macular degeneration, other macular degenerative diseases, histoplasmosis in my area plays a role, degenerative myopia, trauma, all of those. So looking at this patient's left eye, there's really not a whole lot of disease going on. So my assumption at the point is this lady has an idiopathic choroidal neovascular membrane that's gone beyond treatment, is already caused this damage. So we watched the patient over the years to see what happens. So I'm gonna do a time elapse. In about 2019, she starts showing signs of age-related macular degeneration in the fellow eye. So as you might see in that red arrow as going down, the RPE is showing some distortion, drusenoid lesions are forming. In the photograph, which is a near IR photograph, you can see those tiny spots in that blue area as I delineated. Those are drusen, and reticular pseudodrusen particularly shows up really well in a near infrared or an infrared image. And you can see between 2019 to 2021, the leap and the progression of this disease. So if I'm looking at a patient like that, whose fellow eye has already converted to wet macular degeneration and a significant sort of stage of age-related macular degeneration, this patient becomes high risk to have the same problem in this eye. So you have to do, you know, patient education, smoking cessation, eating well, the antioxidants, and most importantly, to educate this patient why is it essential for us to keep a watch on it, even though she may not have any symptoms in this eye. Her symptoms actually in this eye comes from vitreous floaters. She talks about her floaters, but other than that, she thinks the left eye is doing good, and you have to say, no, you hopefully you never get to that stage the right eye got, but there's no guarantee you won't either. So it's by careful examination, because if the choroidal neovascular membrane starts in this eye, or a small geographic atrophy lesion starts with this eye now, you have to intervene to minimize the damage of the morbidity of the disease.
Great. And you did mention nutrition briefly as you were going through that case. We actually have a question from an attendee. What is your stance on the use of nutritional supplements like vitamins and antioxidants in AMD management?
So I do personally follow the NIH rule. The NIH recommends the AREDS2 formulation for patients who have intermediate AMD. So these are patients who have pretty much large size drusen, which is about 125, medium to large size drusen, and RPE abnormalities, pigment abnormalities. Or a patient with early AMD, like this patient, whose fellow eye has already converted. But if I see a patient in their 20s or 30s that are at risk or they're worried about because mom and dad has it, I don't really recommend the AREDS2 because of the the degree of zinc in it. In those patients, I would recommend doing, multivitamins with lutein and zeaxanthin, lesser zinc dose perhaps, but I pretty much follow the NIH guidelines from the age-related eye disease study.
Great. There's another question from an attendee. Do you utilize any genetic testing to assess risk of AMD in patients with a family history?
So from the genetic testing for AMD, I really haven't so far, but I'm talking to one of the companies who provide genetic testing, and I do like to start implementing that in my practice. I do the genetic testing for inherited retinal disorders. But part of the reasons I like to see if I can implement that in the office, although I want to do it in a fashion where the patient is more responsible for paying it, so it's not done through my office and what have you. So that becomes a little gray zone. Recently, I saw a young lady that was sent to me with possibility of AMD, but she doesn't have AMD. She's in her mid-40s. I'm looking at this lady, I'm like, well, your OCT doesn't show any signs of AMD. What's going on? She's an OBGY surgeon whose mother and aunt has really bad AMD, and she says she's paranoid about it. So that's the type of patient population that you could offer the genetic testing, but you also have to tell these patients, if you show genotypic propensity to the disease, it doesn't necessitate you get the disease. So that may actually add to your anxiety. So you have to tell that to the patient. The flip side of it is if you do genetic testing on that patient, they don't have the genetic markers, you can, to some degree, give them that ease of mind that you have a lesser chance. That doesn't still rule out the fact that patients may have mutation of these genes as they get older. Things happen in our life. So you cannot guarantee a patient that, oh, you're never going to get AMD because this test, and none of these tests are 100% foolproof. But yeah, I mean, we are getting to a point that we have to pinpoint the disease further and further and see who we really need to keep a closer watch, who doesn't. And again, that I think that may be another piece of puzzle to explain to the patient, why is it necessary for you to have your periodic or annual or every 6 months eye examination? Eye examination is really undermined by several factors these days, all this internet-based stuff and telemonitoring, and the likelihood of or the value of comprehensive eye examination, it seems like is eroding. It's in our job to explain to the patients, why do we need to do this stuff?
Sure. Last question from attendee. Of the research that you spoke about, which is the most exciting to you?
Of the research right now that I'm excited about is potential of these genetic treatments for neovascular AMD patients, because in diabetic retinopathy, when you inject the patients, many of them, after a while, you can sort of wean them off. But most wet AMD patients become a lifetime endeavor to treat these patients. And these are patients who are getting older and older. The caregivers have to bring them. It becomes a bigger issue as far as that burden to care. And when they neglect that care, they come back with disastrous hemorrhages and things like that. So that excites me, that maybe in the future, the patient can have a single injection under the retina in a surgical procedure to reduce the number of injections. And that also creates a better opportunity to co-manage these patients with optometric colleagues who are not like me, who practice in a retina practice. My job is easier. My patients who need injections go from my exam room to the next door where one of my colleagues, medical colleagues, give them their injections. But many of colleagues that are in primary care, secondary case practices, they lose sight of these patients. And that brings me to another point. When you refer these patients to a retina practice for treatment, always make sure you keep your follow-ups with these patients, because they have other comorbidities. They have dry eyes, they have cataracts, they have glaucomas, and often these things may get neglected in the retina practice.
Awesome. Thank you so much for your time, doctor. We appreciate it. Great insights today.
Thank you. You all have a good day.